first.
quickly and things like this. Okay, so gliomas. There's a few things that we look for on the pathology report that help us to guide future decisions about chemotherapy, radiation, watching, etc. Gliomas come in 4 grades, 1 to 4. 1 happens essentially exclusively in children, so we just put that out. Grade 4 is the most aggressive kind and tends to happen in adults over 60, 65. Your tumor on the initial image from Santa Fe looked most like a grade 2, but on the repeat MRI that you had here right before surgery, there were some areas that started picking up contrast, which is a sign of more aggressive behavior, and I was concerned that the final pathology would in fact come back grade 3. And that's what I expected to happen. The neuropathologist here looked through all of the tissue, including the areas of the tissue that had the contrast enhancement, because I sent that to them first to look at and separately. And there's no pathologic features that make it grade 3. So it's a grade 2, which is a good thing. I would love it for it to be a grade 2 without any contrast enhancement, you know, but by the strictest definition of pathology interpretation, it's a grade 2, which is good. It's as good as we could have hoped for. There are some areas where the cells are dividing more rapidly, turning over higher, more active than the other areas, but still not enough to make it into the grade 3 category. But that exists, and it's something that'll play in my mind and Dr. Marr's mind as time moves on in coming up with a treatment plan. But again, grade 2. The other things that we look at that are probably way more important in 2015 is the genetics of the glioma. So there's 2 mutations in particular that we look at. One called the IDH mutation, that's isocitrate dehydrogenase. If you have that mutation, it's part of the metabolic pathway, the energy pathway of the tumor. If you have that mutation, it is way, way, way more favorable. Not just a little more favorable, way more favorable. And you have that mutation. It's great. And the other one is whether or not you have the presence of some deletions on a couple of chromosomes, 1p, 19q deletions. And if you have those deletions, it's better, and yours are deleted.
Wow.
That's good. And the gliomas come from, these kinds of gliomas come primarily from 2 cell types, either oligodendrocytes or astrocytes. Dendroglial tumors, oligodendrocyte-based tumors are better, and that's the kind you have too. So in terms of all of the sort of microscopic examination, genetic examination, we have the best scenario we could have hoped for going into surgery. And the post-op scan shows that, you know, there's 2 areas on that scan, if you remember. There is sort of a darker gray area that had that little patchy enhancement contrast in it, and then there's some brighter feathery stuff at the edges. The goal of surgery was to remove all of that dark gray. That's the mass. The feathery white stuff at the edges is by and large just reaction in the adjacent brain. And your post-op scan shows that all that dark stuff is out. It looks good, like mission accomplished. The bright white stuff, that area will watch over time, because when these tumors recur, they tend to recur in that area. But it's not worth going after them initially if they look entirely reactive, because those areas contain functional brain. And you would incur a much bigger deficit, maybe loss of all the vision on the right side of your field, things like that. And so that stuff was left behind on purpose. It probably represents mostly reaction. It's almost certainly where the tumor will recur in the future, but we'll deal with that when that comes. And like we talked about—
Could it be 10 or 20 years?
Yeah, it could. I think unlikely 20,
Okay.
if we're just being fair.
Right.
But it's probably not 1 year either, you know? And
5 to 10, 10 to 15.
I think so. That's what I'm thinking. But again, we're all just speculating, and it's a prediction based on how many, many patients who look like you and had tumors like you did, you know, for the past 30 years. But it's the best science and best data that we have. And Dr. Marr will talk to you about the benefits of doing chemotherapy now versus deferring for later. Based on her conversation in tumor board, I think her feeling is that if was certainly that if all the genetics came back very favorably, she wanted to defer chemotherapy and radiation for
5 or 10 years.
until it shows recurrence on scan.
And meanwhile, something else could be coming down the pike or
Yes.
not.
Yes, absolutely. So her lab in particular, she's a scientist as well as an oncologist, does a lot of research on isocitrate dehydrogenase, which is just
What we have.
coincidental and awesome.
Mm-hmm.
And in fact, she is running one of the biggest clinical trials in the country about targeting the isocitrate dehydrogenase mutation. And when I was at Sloan, the oncologist at Sloan would come down here to meet with her and her team to figure out how to do it and to bring that stuff up to New York. So if you've got a low-grade glioma, I think that her group and her as your oncologist are
Thank you.
sort of awesome. And I mean, she could be in Boston, she could be in New York, she could
Yeah.
be somewhere else, and we're lucky that she's here, and we're lucky that her area of interest aligns well with
Mom.
what you're dealing with. Yeah.